this program of the PCOS Society of India, which is along with the Monash University, and we are focusing on the guidelines which have been developed, the latest international guidelines which have been developed by the various organizations, which have included almost 37 organizations which have come together and led by the Monash University and CRE PCOS. And these guidelines have been published in the fertile sterile and the human reproduction. So here we will see the just a moment, please. I'm not able to see this. So these recommendations have been put up in the Fertile Sterile Journal and Human Reproduction, and these are available to everyone on the link, which is available to all on the Medline search. Now here we have got various organizations which have participated, and I'm happy to tell you that the PCOS Society of India was part of the development of these guidelines and Hyperandrogenism. And the second question is the clinical need to determine that when we have a woman with suspected PCOS, what do we do what is the most effective measure to diagnose PCOS when the related biochemical hyperandrogenism? So the question remains is how do you diagnose clinical and how do you diagnose biochemical hyperandrogenism, which both there is quite a bit of a dilemma as to how do we come to a conclusion, and many of us have found that we have not been able to come to one conclusive statement for both, and hence these guidelines will help us a lot in determining what we should be doing to discuss hyperandrogenism. So today we have with us Professor Joop Levin, who will be discussing with us on hyperandrogenism in PCOS. And Professor Joop is the Professor of Reproductive Endocrinology and Infertility. He has been initially trained at the University of Utrecht in the Netherlands, and he has a particular interest in the management of PCOS, the entire spectrum of the syndrome, and he focuses his attention mainly on women's health, reproductive endocrinology, including menopause, infertility, and assisted reproduction and pregnancy outcome. He's a visiting professor at the Shandong University in China and has published over 260 peer-reviewed papers, several reviews, and chapters in books. He has delivered over 400 lectures to international scientific audiences, and he's been the former member of the editorial board of Human Reproduction Update and Human Reproduction. As currently, he's the active associate editor for the Journal of Endocrine Society. So, Professor Joop, I welcome you to this forum, and thank you very much for giving us your time and your expertise on this very, very important subject.
Thank you. Should I now share again this button or not?
Yes, yes, please share. Please share your presentation.
Okay.
Yes.
So here it is. Yeah, first, can everybody hear me?
We can hear you very well, Professor.
Okay, very good. Well, first of all, thank you for having me for this webinar, which is also for me quite a new experience. And after some initial issues with getting the system set up, I would like to start with, let me see, how do I... just to show you some of my disclosures, and apart from unrestricted research grants from Ferring, Merck Serono, MSD, Organon, Serono, and Schering-Plough, and these companies, I don't have anything to share with you as far as my disclosures are concerned. Because these people and these pharma institutions made it possible to do a lot of research, which I'm doing in my department. So we started this whole endeavor about 2 years ago, in which we decided to stick to the PCOS definition, which we actually decided on in 2003 in Rotterdam, the famous Rotterdam criteria. And we decided, at least for clinical purposes, to stick to those, which were originally oligoamenorrhea, defined as a cycle length longer than 35 days, hyperandrogenism, either defined as hirsutism, which is clinical hyperandrogenism, or a free androgen index which is exceeding 4.5. PCM was back in those days decided on that we would say that you should need more than 12 follicles between 2 and 9 millimeters in one or both ovaries, or an ovarian volume of 10 ml. Of course, in the new guideline, these things changed, and that had to do with improvement in clinical technology, like, for instance, ultrasound machines. If you're using an ultrasound machine with a megahertz which is exceeding 8, so if the probe is exceeding 8 megahertz, then you need to tune that figure up to 20 follicles between 2 and 9 millimeters. Although the ovarian volume more than 10 ml is still applicable. Depending a little bit on what technology you're using to measure androgens, you also should see that your free androgen index is going down, actually, because with modern technology, I will come back to that later, you're more sensitive to detect, let's say, hyperandrogenism. And as you all might know, 2 out of 3 is enough, so you need either oligoamenorrhea, hyperandrogenism, clinical or biochemical, or PCOM, and then you have PCOS. And that basically gives you about 4 different phenotypes. So the full-blown phenotype, ovulatory dysfunction. In which area of the Asian continent you're looking, the prevalence might be different. They have lower BMIs in the northern parts, mild hyperandrogenic phenotype, much more similar to the phenotype where most of the literature goes about, women in the Western world or Western derived, like in the North Americas. They have a relatively mild phenotype if they are white Caucasians. We prefer Western descent because there again, white Caucasian might sound a little bit discriminatory. In the Middle Eastern areas, women are much more affected by hirsutism, which is also true for women in the northern parts of the African continent, which we call the Mediterranean areas. And Mediterranean women are more hirsute compared to others. Africans, we know not that much about women in the African continent and how PCOS looks like there. But we are embarking on a study now in which we are looking in Nigeria and in Ghana at incidence of PCOS and what the distribution of phenotypes is there. We, of course, have some colonial history with Suriname, which is one of the countries in Latin America. And these women are very much mixed with women from eastern and southeastern areas from the Asian continent. And they also share this insulin resistance, which makes sense. On the other hand, what a lot of studies showed in the genetic studies which we did was that if you also look in Western European in the Western European continent, that a lot of these women are actually mixed in a genetic way. So therefore, it's not appropriate to talk about ethnic differences. You should really look at how genetically different they are. So what about biochemical hyperandrogenism? It's good to keep in mind that not everybody is hyperandrogenemic, because there is also this phenotype of ovulatory dysfunction and PCOM, and these women are generally not hyperandrogenemic. They're also not attending a doctor because they had the hyperandrogenemic women with PCOM, for instance. They probably don't know that. If they only have biochemical hyperandrogenism and ovulatory dysfunction, then they will generally not attend the doctor because they don't seem to have a problem from their point of view. As long as you don't determine that in everybody, you will not, let's say, find these patients in your daily practice. And although we should restrict ourselves to our daily practices, of course, but that's also good to keep in mind that it's a highly selected population of patients. The other thing which you should keep in mind, this is a study which we did years ago, in which we looked at different age classes in women with PCOS, and what you see is that testosterone levels in women with PCOS, they decrease over time. The same is true for androstenedione, the same is true for DHEA and DHEAS. So all these values tend to be lower when you approach your menopausal age. So that might be the case that in a young woman you find an elevated free androgen index, but that if she advances as far as age is concerned, that her androgen levels are not abnormal anymore. So keep that in mind. And especially in the beginning, this is the free androgen distribution in the 4,500 women we have in our hospital, because we have, I think, one of the biggest databases on PCOS in Western European women. And there you see that there is a considerable amount of women which do not have a free androgen index, which is elevated at all. It also matters how you measure this. If you're using a RIA, so a radioimmunoassay, or what is now most of the time, let's say, advocated that you should use liquid chromatography, so MS. And if you do that, if you use mass spectrometry, then you should realize that values which you measure with LC-MS, MS, they are generally lower. Although most of the women, this is a study from Preeclampsia, in which they looked at they compared the different LC-MS technology with a RIA, and there you can see that they generally have lower values compared to the values which are measured with a RIA. There is a good concordance between the different comparisons, but keep in mind that if you use LC-MS, MS, and most of the world is doing that nowadays, that you measure actually lower values. So you should adjust your previous values based on RIAs in your own clinic to a lower level. For instance, the free androgen index is now somewhere around something like 2.5, 2.9 in my clinic. Went down from 4.5 since we introduced this LC-MS. All these values, doesn't matter what technology you use, they also very much correlate with your Ferriman-Golby score. They also correlate with clinical hyperandrogenism. So that's a good thing to keep in mind, that there is a certain correlation between that. The other thing is, I told you already that androgens go down with an increasing age, and this is a very nice study from the North Finnish birth cohort, in which they looked at sex hormone binding globulin levels, and they also looked at testosterone levels. And in red are the women with PCOS, and what you can see actually, if you are entering the postmenopausal period or the post-climacteric period, then you see that women with PCOS still tend to have significantly lower SHBG levels, and they also have significantly higher testosterone levels. So probably the only remnant of hyperandrogenism which is still there postmenopausal is hyperandrogenism. Because the other ones, you're not going to find that anymore, because your ovary is depleted from follicles, so PCOM has gone, and your cycle has gone anyway, so ovulatory dysfunction is not present anymore. And they also looked at the free androgen index, they looked at all kinds of different let's say, calculated androgens and other androgens like androstenedione and DHEAS, and they basically show the same. Women with PCOS tend to have higher androgens post-menopausal compared to normal controls. What we know, of course, is that there's a high degree of heritability in women with PCOS, and if you encounter a proband, let's say, with an elevated testosterone level, she has about 25% chance to share a similar testosterone elevated level. She might have about 25% chance that she is only sharing that specific characteristic without having the other characteristics for PCOS. And about 50% of the sisters are unaffected, which gives you an impression that in women with PCOS, there is a kind of trimodal distribution between normal sisters, sisters which only share one particular characteristics from PCOS, and the ones which share the same phenotype or have even a more severe phenotype. Compared to controls, there's only a bimodal distribution. In normal controls, from time to time, you find also elevated androgen levels, testosterone serum levels I'm talking about now. But you don't find the full-blown phenotype here. So be aware that it runs in families, as we know, and that's also true for hyperandrogenism. There is some debate about whether we should measure other androgens which are more constant in time and which are maybe differently distributed. This is a relatively new study from an American group led by a former German woman, Wiebke, and they looked at C19 steroid derivatives. And they show that there is, although subtle, difference in these 11 keto steroids between women with PCOS and controls. I don't know. We really should know. We really should look more into that. We are doing that in our large database now, but I didn't have the data yet. So what about clinical hyperandrogenism? The way to measure clinical hyperandrogenism, I can say that not often enough, that should be the modified Ferriman-Golway score, and use a visual scale like this, in which you just tick the ones which you see, because that will definitely give you a much more objective approach of these women. In Southeast Asian women, we have a kind of modified Ferriman-Golway score of 5 or 6, and there was a lot of debate about that. It's 3 indicative. There are only very few studies which looked at that in a very good way. This is a study which was about 10 years ago, was published, or 13 or 15 years ago. They looked at black women and white women, and they saw that in black women, hyperandrogenism is much more common than in white women. So probably these women need a different cutoff. This was the former cutoff, and these are new cutoffs which have been decided on. The other thing which you should keep in mind is there's only one very good study. This is a Chinese study in which they did the proper approach. Because what a lot of people do is they say that your, let's say your levels, if your levels are below the 5th percentile or above the 95th percentile, then you have a high chance that the level which is measured in that case is elevated or is too low. If you look at the incidence of PCOS as we know it now, which is probably as frequently encountered as in 15 or 20% of all people out there in the real world, then the 5th percentile or the 95th percentile is probably not the proper cutoff. What these people did, they looked at different cutoffs, and they also took an approach which is, without going into detail, a very complicated mathematical exercise, which is called a cluster analysis. And they came up with clusters, and if you look at these different clusters here, you could see that the cutoff here is 5 for women, and this was in Chinese women. And they also looked at defining hirsutism, and they did a similar cluster analysis here, and what you can see is there is a kind of age trend, but it's not very obvious. It's only in youngsters that you find it very often, but thereafter also hirsutism shows a tendency to go down. But the cutoff is quite clear cut here. It's 5, and that's why we choose in the guideline this cutoff of 5, because this is the best approach to do that, because looking at different percentile cutoffs is probably not a good way to do that. There again, there are differences in phenotypes between different women with different ethnic backgrounds. And what you also should keep in mind is a lot of these women which you will see are on oral contraceptive pills. combined pills. And this is a study which one of my former PhD students did. She looked at the incidence of polycystic ovarian morphology, elevated androgens, and hirsutism. And then she looked in a similar cohort which were using the oral contraceptive pill. And that does not affect your PCOM incidence, nor your, so neither your PCOM nor your hirsutism incidence, but it does dramatically affect your biochemical hyperandrogenism level, because that goes down. It's only in 4% of cases, and that's a kind of long-lasting effect. We think it takes at least a year for a woman, or even more, if she stops the oral contraceptive pill, to reach her initial androgen levels again. And that has to do with a gradual decrease in SHBG levels and a gradual increase in androgen levels. So what we do in a lot of pediatric patients, we give them OCP, but that rules nearly out that in, let's say, if you evaluate them after, let's say, 6 or 7 years when they are post-adolescence, let's say 22, 25 years, then they generally will not show you that level of hyperandrogenism which you initially encountered in these patients. So what about the genetics of hyperandrogenism? There's a lot of stuff which we did in the past. This is a study which we did with Didier de Roilly, and this shows the relationship between different parameters which are put here in the outer circle. And if you're outside the black circle here, then there is a significant relationship between these things. If we looked at what happens in normal controls, you see that androgens, total testosterone, DHEAS, free androgen index, they're all, in a way, related to each other, significantly. They're not related with LH, with follicle number, with AMH, with BMI, with waist circumference, because the green line here is overlapping with the black line. The same is true for BMI, waist circumference, and HOMA, which makes sense too. There is a little bit of relationship with the free androgen index, if you look at that area. And if you look at the blue area, LH, follicle number, and AMH seem to be related to significantly, which makes sense. If you look at the same thing in women with PCOS, then also androstenedione and testosterone are related significantly with this thing. And that's a little bit different from what you see here on this side. The biggest difference is actually seen in the green line, because the red line is basically the same as what we see. So there is a big difference here in this one, and there's a big difference in the blue one here, which indicates that in women with PCOS, these things are differently related to each other. And this is an interesting one. This is the first GWAS which was ever done by the Chinese. And this shows the different SNPs which are related with the PCOS phenotype. And look at, most of them are related significantly with PCOS, which makes sense, of course, because we were looking for that. But it also makes very much sense for PCOM, which is heavily debated whether that should be a criterion to use. It's not. It's a little bit. It's in a similar way related with ovulatory dysfunction, but it seems not to be related at all with hyperandrogenism, LH, testosterone, for instance. So basically, that makes, let's say, the genetic background is not that much driven by hyperandrogenism. This is what we did in a large meta-analysis recently, and again, testosterone itself is not very much related. Hyperandrogenism is a little bit more related, but it's PCOM and ovulatory dysfunction which are very much related with the genetic background, and it's not that much driving hyperandrogenism per se. So what about treatment outcome? Is it worthwhile looking at hyperandrogenism anyway? These are studies which we did in the late 90s, and this is the famous nomogram looking at free androgen index, BMI, age, to, on the one hand side, predict the chance of ovulation, on the other hand side, to predict the chance of live birth. And look how androgens play a role there. This is a free androgen index which is quite high. It's a little bit above 5. Let's say she is oligomenorrheic and she has normal BMI, then she has about 90% chance to ovulate on clomiphene citrate. If you take the chance to this side, 90% here, let's say she is oligomenorrheic and she is 30 years of age, then she has about 30% chance of having a live-born baby after clomiphene citrate cycles. The truth is somewhere between 24 and 40%. If you look at what happens if the woman has a higher free androgen index, and for instance she is amenorrheic, and most of the time she will be obese with such high free androgen indexes, then your chance goes dramatically down to something like 35%. If you take that 35% here, she is amenorrheic, she has about the same age, let's say, then her chance is less than 15%. So it's about half of that of the lean woman with a lower free androgen index. So androgens do especially affect your treatment outcome. And this is a study from Rick LeGros, and without going further into detail, you see that the women here, down here, they have a very poor chance compared to the women which are up here. They have a very good chance, and they have a low body mass index, they are young, they are less than 1.5 years attempting, and they are not very hirsute. These women are very hirsute, they have a high body mass index, they are attempting longer than 1.5 years, and they are generally older, and they have a poor chance of getting pregnant. This is true for the combined group, this is true for the clomiphene group alone, this is true for the metformin group too. And again, this is another study which looked at different factors which we are looking at in this study, which we did with a fellow from the US, in which we looked whether hyperandrogenism was predictive for preterm delivery, and it was also predictive for preeclampsia. So the more hyperandrogenic you are, the higher your chance for preeclampsia and preterm delivery is. So there again, androgens play a role. This is a study in which we tried to, let's say, predict gestational diabetes in PCOS, and there again, androstenedione was a very strong predictor in that study, which showed that, especially if these levels were high, then you have a high score, because if you look at the green woman here, she has a generally low score, she has a very high score, and that predicts that she might have a chance of 60–70% to develop gestational diabetes in the oncoming pregnancy. So there again, androgens are also a suspect which do say something about long-term, about the complications in pregnancy. What about long-term health issues? That's a little bit more there's a little bit more controversy in that area because studies are contradictory. We looked at hyperandrogenic PCOS women and the non-hyperandrogenic ones, and we showed that they much more often had dyslipidemia. They were much more affected by metabolic syndrome. But there is a similar study, and that, of course, explains. This is a US study in which we looked at the incidence of metabolic syndrome in women with PCOS. And it doesn't matter whether you look at the different age strata, you see that the incidence of these of metabolic syndrome is dramatically elevated in women with PCOS compared to normal controls. But this is a study from the North-Finnish birth cohort, in which I'm participating too, and they looked at the same thing, and they didn't find any differences between the women with hyperandrogenic and non-hyperandrogenic women with PCOS. They were not different at all. So there again, the cardiovascular and the metabolic profile, it depends very much on the study who is looking at these things, because these were the ones which were very different, and the other ones were not. You should look at this last column here. What about androgens and cardiovascular disease markers? There's a lot of discussion about that. this is summarizing the studies which did look at that, and they did find some, let's say, significant relationship between androgen levels, elevated androgen levels, and cardiovascular disease. But there's a similar number, or a few more studies actually showing that there is not such a relationship. Then we looked in the Rotterdam cohort, the ERGO study population. That's an area which is located here in Rotterdam, in which every inhabitant is offered a general checkup every 5 years. And by doing so, we were able to look at that population and look at all the two androgen levels. So we compared the highest testosterone level with the median levels and the lowest levels, and we didn't find any increase in risk for intima media thickness, pulse wave velocity. We looked at hard endpoints because a lot of these women are now somewhere between 75 and 80 years of age, which is the age at which you at least should see some of the cardiovascular disease endpoints. And if you look at coronary heart disease, stroke, and cardiovascular disease in general, you see that there's not a significant increase or hazard ratio for women with high androgen levels compared to the ones with lower androgen levels. We were also able to identify in that group 106 women in which we definitely knew that they had PCOS because they were diagnosed at age 25 with that. And so basically they share the phenotype which you would expect there. They have higher androgen levels, lower SHBG levels, and so on and so on. So they really have, they share the PCOS phenotype, also postmenopausally, what you would expect, higher androgen levels there. And if you look at the cardiovascular disease-free survival, they're basically the same. They end up to at the same level. And the same is true for stroke-free intervals and coronary heart disease-free intervals. So basically there, it looks like that PCOS, well, everybody is very much worried about, that androgens are the driving force behind stroke. That's not the case. And that's very much in favor with the study, the only study which looked at 25 years follow-up in about 80 patients with PCOS, formally diagnosed according to the Rotterdam criteria, which is this study from Eva Dahlgren's group in Sweden. And they showed basically that although these women had a higher prevalence of type 2 diabetes, and they also had a higher prevalence of hypertension, they did not die of cardiovascular disease. Because if you look at the stroke incidence, they were higher actually, and hospitalized due to stroke, hospitalized due to myocardial infarction. These figures were generally higher in the controls than they were in the PCOS women. And overall mortality rates were higher in the controls compared to PCOS women. So it seems that they are protected against that. We don't know actually how that works. I could talk about that another hour. I'm not going to do that. This gives you my take-home messages. So patients do care about different issues compared to physicians. Patients care about fertility and irregular cycles and about polycystic ovaries. They generally do not care about hyperandrogenism. Physicians are spending too much time in debating about definitions, as far as I'm concerned, which didn't bring us any further. It really seems not to matter for the patient's perspective. We should try to stick to what we consented on from the consensus meetings. And I showed you some data on cardiovascular disease. I showed you some data on how hyperandrogenism should be interpreted. And having said that, I'm happy to take any questions. This is my team, by the way, because without these people, everything which I was telling you should not have been possible.
Thank you so much, Joop. I think that was an excellent presentation and very good information related to hyperandrogenemia. As a matter of fact, we know that PCOS women, one of the diagnostic criterion is hyperandrogenism or hyperandrogenemia. when we look at hirsutism in women today, young girls don't walk around with extra hair growing anywhere. They're either removing it or they are lasering it or temporary measures. But so when they come to us, it's really difficult for us to determine whether these you're having trouble with you. Are you okay?
Yeah, I'm fine. I'm just otherwise I don't look at you.
Okay. Now is it okay?
Yeah, it's fine.
Good. So when we look at women who have hirsutism, I mean, how do you assess the FG score when they have removed all the hair?
Yeah, well, most of the women which are doing that in my department, they are used to do that because people are very much ashamed about letting their hair grow, of course.
Yes.
We generally tell them that they should not shave for a day or so, because then you're generally aware of, if you see all these coarse black hairs, then you can really identify, and then you can do a modified Ferriman-Galway score anyway. So that you don't need really, let's say, very a strong beard or yeah. So basically, don't try to get them not shaving because that's not going to work. And if you look closely, even in women which are shaving, you see if there is real hirsutism, and let's say to a certain extent, then you see these black coarse hairs.
Yeah.
Anyway.
So we do see them because when you read the definition of hirsutism, they talk about a 0.5 centimeter long hair. And the definition when you read is, I think it needs to be changed a bit because no girl today does that. And most of our girls here in India actually laser their hair. They undergo laser therapy and get rid of all the extra hair, and they're doing it for years together. It becomes
but the problem there, Duru, is that probably that's what I tell my patients, at least, it's not going to work as long as you don't take away the reason and the cause for that. So if you're not treating, let's say, hyperandrogenism, then the problem is that you're not in any way at all taking away the cause, and that's probably why, let's say, these women are visiting these clinics over and over again. And they like those clients, of course. They know for sure that they are coming back. The other thing is also depends very much on the age of the girl, because we see a lot of girls at least in the western part of the country, of the world here, which do have some hair on the outer margins of the lip, and that's in the beginning black and coarse hair, and they very much are worried about that. I always tell them, listen, wait till your 22nd, 25th year, because a lot of these things will be gone by that time. And of course, entering puberty, your androgen levels rise up to an age of, let's say, 19 or 20, and then thereafter they properly assessed, then going according to the guideline, because it might as well be, the guideline is providing guidance. It's not a kind of rule of the which is applicable to everybody. We are, especially if you're looking at hirsutism, we are saying a lot about that in the guideline, that there is need for normative data for women with different ethnic backgrounds. And you should establish that in your own country, I guess, or for, let's say, Southeast Asian women which are genetically related. And although a lot of Indians are genetically and look similar, they might be very different in a genetic way. That's what we see in women in Europe, for instance. Even in the Netherlands, there is a kind of mixed population there.
Yeah, actually, if you see India, and if you go to the north of India and you see South India, women look totally different from both the different parts of the country.
Yeah.
And I'm sure they have a little genetic variation which will be there. But suppose we do have the normative data done in our country, which androgen would recommend that we assess, and which one would you recommend for PCOS women? Because the confusion is, should we do an androstenedione? Should we do a total testosterone? Should we do a free testosterone? Should we do a free androgen index? Which hormone would you recommend?
Yeah, well, what we are doing here is we are measuring all the androgens.
Mhm.
And we do a very big steroid profile, including these 11 keto things. There is one student now working on that, and they do not add anything, as far as I'm concerned. So stick to testosterone. If you do a RIA, you're not doing the things wrong, but LCMS, MS is much more sensitive. If you do LCMS, MS, you get all the other androgens anyway, because that's done in one run. So if you would be interested in that, how that would be, whether that would be different in the Indian population, you should do that, I think. And I might provide you some data which we have on that. But then still, if you would like to have a minimal approach, measure sex hormone binding globulin and testosterone. And then use direct assays and not the indirect assays, because they are notoriously unprecise. And then you have a free androgen index, which is, if you use a RIA, which is 4.5 or higher, if you use LCMS, you will end up somewhere around 2.93.
Fine. So in short, we understand that we need to, in the clinical scenario, obviously we cannot do all the assays because it's too expensive for a patient who has to spend from her pocket. And therefore, we look at one good measure which will help us. And instead of doing a free testosterone, we should be doing a free androgen index. Is that what you would recommend?
Yeah, but then you need to measure testosterone, of course, and SHBG together.
Yes.
Because it always needs, you need two measurements.
Yeah, so when we do the free androgen, sorry.
Yeah, sorry to interrupt you, but the advantage is also that if you look at, sometimes women do have a normal free androgen index, and they do have elevated testosterone levels. You will miss them if you don't measure testosterone. On the other hand, if you measure testosterone only and you have a normal level, and you don't measure SHBG, which is especially in the women which are overweight, very low, then they might have a free androgen index. Although testosterone levels are in the high normal range, they still have an elevated free androgen index.
So actually, when we have our free androgen index measured here, it is actually doing the level of SHBG and total testosterone, and from there they evaluate the free androgen index. Is that the right way to do it?
Yeah, that's the right way to do it.
Okay. So that's regarding the assessment on looking for hyperandrogenemia and looking at clinical pattern of hyperandrogenism, which we say we do the FG scoring. Do you tend to use the Ludwig score for the alopecia, or is there any tool which you can measure acne with?
There are some tools to measure acne with. We use the Ludwig score for alopecia.
Yeah.
Although I'm personally not very convinced that acne is a very sensitive phenotypical feature of PCOS, which we said in the guideline too. There are some scores for acne, but there's a lot of debate about these scores, whether they are clinically applicable. You should restrict yourself to use that score only in adult women and not in adolescents or teenagers, because they have elevated androgen levels anyway, and therefore they are more seborrheic, and that's why they also have more acne. That's probably for, let's say, the acne you can see in the face. If you have acne on your cur or on your back, that's a more sensitive way. And you see, if you look at patients, adult patients with PCOS, if they are complaining about acne, they are complaining about that particular form of acne. So in these women, it might be predictive again, but we are not very much advocating to use visual scores for acne.
Okay. But at least you would not consider acne as a marker for hyperandrogenism in young girls under 18?
Definitely not.
Yes. The other question is that a lot of these young girls are using the oral contraceptive pill for contraception. And that sometimes masks their acne, which you would not see. And it also helps, reduces the androgen levels. So if you have a PCO patient who's on oral contraceptives, how would you diagnose her? She's 22, she's 23, she's got regular periods with the OC pill, she's got hardly any acne, her hirsutism is hardly there. Would you pick it up anyway?
Well, we are assessing them, let's say, the way we are assessing these women is we wait, we instruct them to have a kind of stop week in between. So if they are taking it continuously, or if they use an intermittent regimen, then we assess them on day 8 before they have taken the first pill of the next strip. Knowing that around that time LH levels and FSH levels are not that depressed anymore. Most of the time they have normal estrogen levels, but androgen levels are not very reliable because they are generally decreased. And what you see in all these girls is they have high levels of SHBG due to estrogens in the pill.
Yes.
So if they have PCOM and they had irregular cycles before they started the pill, then I'm very much in favor of giving them the diagnosis. Especially if they have family members, that's another thing. I recently talked to a girl which said, yeah, but you know, I lack this hyperandrogenism thing. She was taking the pill for 6 years already. She has 2 sisters which have the syndrome and a mother which has the syndrome. Yeah. Probably, she also had PCOM. That was the only feature we saw. So I told her, listen, probably you have hyperandrogenism too. There's about 50% chance that you share that with your sister. And then you have the syndrome anyway. Basically, yeah, is it important to have that diagnosis? I always discuss it with them, and I always ask them, how does it impact on you? Some of these girls are very disappointed in their own body, because they say, yeah, you know, it's not functioning properly. Others are not very much concerned about that. At the end of the day, you're treating them correctly by giving them the pill. And the second thing is, of course, basically, they come back to you if they want to conceive. And at that time, you stop everything and look. Most of the time, they did that already. And they tried for another few months whether their cycles will regain a regular pattern. And in case that doesn't happen, then they will visit you anyway. So that's basically how we approach these women. Yeah. There's also some extra information around that. If your family history is very much, let's say, indicating that PCOS is running in your family, yeah, you should be a little bit milder in not, let's say, counting that much on hyperandrogenism, because yeah, you basically have that's gone by giving them the pill.
Yeah. So if you have a girl coming to you who's about 20, 21 and has been on the pill for the last 5 to 6 years, and she comes to you for some other reason, would you recommend to her, you don't know whether she's PCOS or not, probably a family history is there or an ultrasound is showing PCOM. Would you recommend to her to stop the pill for a few months, get evaluated, and then restart again? The reason is...
Yeah, we discussed that extensively in the group which I was sharing about how to deal with that, and I think the risk of having unwanted pregnancies is much higher when you do that compared to assessing them the way we are doing that. So I would not very much be in favor of stopping the oral contraceptive pill in these youngsters. Basically, I tell them what I told you. It's only important for the diagnosis, and if the diagnosis is correct or not correct, it doesn't matter, because they need either the pill for contraception or they need a pill to keep their androgen levels down. And you're doing that actually. Explain that to them, then tell them about when they want to have a pregnancy. they should stop the pill and see what happens with their cycle, but they should then at least come back to your office for a proper assessment. And really, Doro, we don't know whether you have to wait 3 months, 6 months, or a year to have these androgen levels back at the level where they ought to be, because nobody actually knows that.
Okay. So as a matter of fact, that's exactly what I was coming to, that, you know, a young girl, a girl who's stopping her pills after getting married and straight gets into a pregnancy without coming in for an evaluation. Many women do that, at least in our country. They come back to you only when they are pregnant. They haven't done any pre-conceptual check. They haven't done anything. And the concern today is that if it's a PCO woman who's hyperandrogenic, what could happen to that fetus? That's the concern.
Yeah. Well, we really don't think that the damage happens in the beginning of the pregnancy. So that's something which makes it, let's say, less dangerous what they are doing. We see a lot of these women too. Actually, they come to your office and they be already pregnant. So what we are trying to do is, as soon as we identify them, assess their carbohydrate metabolism, because they have about 4 or 5 times higher chance to develop type 2 diabetes, which is much more affecting their offspring, I guess. The other thing is that we follow them. In the Netherlands, of course, a lot of women do deliver at home and not in the hospital. About 30% of all deliveries are done at home. So a lot of women with PCOS, as soon as they get pregnant, they will go to a midwife and they will say, yeah, PCOS is not an indication to be in the medical line and to consult a gynecologist. We are on the verge of trying to change that in the Netherlands, because we see a lot of issues in women which are pregnant with PCOS. And if you have the possibility to do a prenatal screening and a preconceptional screening, please do that and try to adjust lifestyle, which is most women which we see they are basically aware of the fact that PCOS has something to do with lifestyle. And they already adjusted their lifestyle quite dramatically in most cases. If they didn't do that, then it's your duty, I think, to point out to them that a healthy lifestyle is a necessity. Losing weight is a thing which is going to at least improve your treatment outcome, as I showed you. And losing weight is also improving your androgen levels. Because what we basically see in the big randomized trial, which we recently did, in which we looked at non-interventions or interventions patients do themselves. And the program we are offering them, which is lasting for a year, then we see that androgen levels and all kinds of different parameters associated with the syndrome are definitely improving. So basically, you should tell them that we have a very strict policy. If you're overweight or obese, you have to lose 10% weight before we're going to treat you. Yeah. And that's, of course, very strict and also a little bit paternalistic, but then still, we see better outcomes after we introduce that regimen, that strict regimen, compared to what we, or to say, let's say, what we saw in previous years. So prenatal and preconceptional consultation and information is very important. On the other hand, yeah, about half of our patients enter your clinic and they are already pregnant. Then we focus very much on trying to prevent secondary harm like hypertension, like type 2 diabetes. And you should assess them then in the first trimester or at the verge of the first to the second trimester, and in the third trimester again. So you need 2 OGTTs, and people are very, very, very much trying to avoid that, because if they've done it once, they know how bad it is, and then they try to skip the second one. Yeah. And both are very important actually.
Exactly. That's exactly what my patients, they refuse to take it. They say it's awful And I'm looking for the day when we can get some replacement for that sugar, which they just can't swallow. It's so tough.
Yeah, well, we looked at that too in the guideline, I think it's as best as your OGTT outcome might be your measuring just HbA1c AC. So that's giving you at least the impression that a lot of these women, because we're having discussions at the morning handover here, always say, listen, this woman is delivering a baby. That's her first baby anyway. She has PCOS, and the baby is 4.5 kilos, which is 1.5 kilo too heavy for what the average woman will deliver as the first child. So this woman definitely had type 2 diabetes in her pregnancy, gestational diabetes. Then everybody will reply, no, we looked at that because her blood sugars were normal. I said, you assessed it once in the whole pregnancy. Look at HbA1c levels. Probably they tell you more about that she was from time to time heavily dysregulated and she had high blood sugars. That's why she fed them to her baby, and he couldn't do anything else with that, making fat out of it.
Yeah. As a matter of fact, in India, because the incidence of just diabetes is so high in our country, as a matter of fact, when we were working on the guidelines, I was strongly recommending that we should be doing it for all PCOS women every single year to look for diabetes. And I think ethnicity-wise, Indian women, we strongly recommend that they once a year get their annual sugars done, both the OGT completely done, especially the PCOS.
Yeah. We stress the same thing, and I fully agree with you. We are doing basically the same. The issue here in the Netherlands is who should do it. Because if you say the general practitioner should do that, they say, listen, but then we end up being a screening doctor, and we are a general physician, and we are a house doctor, like we call it. So we know the family, we know all the other issues, and we would keep it like that. So if you would like to screen women with PCOS, do it yourself. And so basically that's why we are ordering them back every 2 or 3 years, in which we assess blood sugars and blood pressure. We look at lipid profiles. That's I think the minimum you should offer them, just to keep track on, because they are in a certain way at risk for things. The data I showed you about cardiovascular disease, you might also explain that in a different way. So I was saying there's no difference there. But if you look at the genetic background of these women, they might much more be protected against DNA damage, which is basically, let's say, the basic thing what happens also for cardiovascular disease and type 2 diabetes and whatever. They all cause also, apart from the things in your blood pressure and in your blood sugar, they also cause damage. Women with PCOS are probably much more capable of repairing that damage. If they end up at a similar level as the normal population, it might be the case that they should be a little bit higher. So they should be healthier in a cardiovascular sense. And they are not. So there's still something to gain there to get them on that level which they deserve to have. And now we are falling asleep and say, listen, they are on the reference population level, and that's okay. But probably they should be on a little bit higher than the reference population. We are looking now into that to see whether that's the case or not. And then, because it's strange in a population like yours, where type 2 diabetes is so common, where hypertension is also very common amongst women with PCOS, that they don't have any hard endpoints there. It should affect their general health dramatically. And probably it pulls them down from that high level. They're definitely different from let's say, I don't like that word, the native Dutch, because that's in my country and nowadays a minority, I would say, because we are sharing this country with a lot of immigrants. Anyway.
But India also has a lot of mixed genes actually, because we've had so many invaders into our country. We've got the Britishers in, we've got the Portuguese, we've got the Mughals, we've got the people from Persia. We've had a lot of mix of genetic material in our country, and therefore most of the genetic studies, they say, are best done in India because you get a lot of genetic variation here.
Yeah, well, you need numbers. That's the thing, and you guys have numbers too.
Yes, yes, absolutely. So we are the right place to do research on genetic analysis.
Yeah.
The next question I'm coming to is that with hyperandrogenemia also there's correlated insulin resistance. The two of them are also associated with each other. As a matter of fact, or hyperinsulinemia. There was a concept that, there was a query, does hyperandrogenemia give rise to hyperinsulinemia, or does hyperinsulinemia or insulin resistance cause hyperandrogenism? So is there any new thoughts on this?
Yeah, well, I think that the interlinking factor there is obesity.
Yes.
So we see a lot of women which are not obese at all. They have high androgen levels and they are not insulin resistant at all.
Mm-hmm.
So basically there is not a clear-cut relationship between these two. I think it's mediated by BMI. If your BMI is higher, you generally also have higher androgen levels. You have lower SHBG levels. Your androgens rise anyway. Only due to that fact, there might be a direct effect of insulin as a kind of co-gonadotrophin further increasing your androgen levels, but it's not working the other way around. And of course, if you have a high BMI, you're basically insulin resistant by definition. And then you're only very few, let's say, meters away from developing type 2 diabetes.
Yeah.
And that's the way I see it. That's also what we showed in previous studies, how the relationship is, and it's not working in the other direction. It's very much driven by BMI, I guess.
Yes. So you have in obese women, most of our PCO patients are overweight or obese. The percentage of PCOS women who are overweight or obese is much higher than the lean PCOs. So you have a factor of obesity, you have...
If they stay lean,
Mm-hmm.
if they are not becoming hyperinsulinemic, and if they are not having hypertension. Because I really fail to see that if you have hypertension in an increased incidence, like women with PCOS do, you are hyperinsulinemic, then it's very unlikely that you're not affected by that in terms of an increased risk for stroke or cardiovascular disease. So probably the default setting in these women with PCOS is that they have a lower risk compared to the general population of having cardiovascular disease. And what we show, and a lot of others have shown, is that the risk is at the same level of the reference population. But that does not necessarily mean that they don't need any care in this respect, because, you should treat the hypertension and you should treat the hyperinsulinemia. And a lot of people are not doing that, also not in my country. Nobody is prescribing metformin to these women, and nobody is giving hypertensive drugs to them. Because everybody says, there are some studies which do not show any advantage of that. That's not what we have said. We only looked at the general population in this specific area of Rotterdam, and there we couldn't see it.
So would you give metformin to these women whom you feel are at risk?
If they do have disturbed glucose metabolism, I would do that, yeah.
Okay.
And I would start with 3 times 600 or something, or 2 times 600 milligrams. And I also would treat them for hypertension.
Yeah. No, but suppose she's only PCOS and she's not really, you first would make sure whether she's insulin resistant. If she's insulin resistant and has all clinical evidence of it, would you, even if her sugars are not disturbed, would you give her metformin?
Well, what you would like to prevent, Duru, is that she develops type 2 diabetes. You shouldn't wait for that, because in let's say, in the way getting there, a lot of damage is already done. And from a preventive point of view, I think you should consider the disadvantages of having metformin and the side effects. Discuss that with the patient and tell her that she probably would be better off when she is going to take it.
Yeah. So that's exactly what I feel. Yes, we should be preventive, go in the preventive mode rather than waiting for things to happen to them when you know that they have at a higher risk.
Yeah, which is a good thing to do. Yeah.
So that's there are a few more questions which I would like to discuss with you. Is that when we have the androgen levels done for women, does it matter what time of the day or day of the cycle or which kind of assay is used for doing their levels? You mentioned about LCMS. But
yeah, well, LCMS is where the whole world is hitting at, and this machinery is getting more and more, let's say, affordable.
Yeah.
I would very much stress the point: if you have the opportunity to have such a machine, do that. Mm-hmm. When you do the assessment, we do it randomly. Mm-hmm. The only thing is we do it after in a fasting state, but it has everything to do, of course, with insulin because we would like to measure fasting insulin and fasting glucose.
Yeah, because we do the other test at the same time. Right.
Yeah, that's the only thing that we keep them to. So we do all these assessments in the morning because you can't keep them fasting for a whole day.
Yeah, absolutely. There's one more question is about women who have high androgen levels, and when you investigate them for infertility and you find they are hyperandrogenic. What exactly do you do? She's lean, she's hyperandrogenic, she's hirsute. She wants to conceive, she's having trouble conceiving. So what would you like to do with her androgen levels before you start therapy?
Well, if you would like to get these androgen levels down, then you need a long period to treat her. And I think our experience is that what I do with women which are complaining about hirsutism, for instance, we always tell them it takes at least a year to get your androgen levels down to a certain level if you are using the oral contraceptive. And most of the women which would like to get pregnant, they would like to get pregnant yesterday instead of tomorrow. Yeah. So you can't sell that concept to them. I always tell them and show them how androgen levels do affect their chances to become ovulatory on using clomiphene citrate or letrozole, although letrozole is still off-label in the Netherlands. The use of that for ovulation induction, at least. And yeah, I show them how that affects their chances. And that it does impact on that, but a lot of other factors do impact on that too. And so basically, if you are lean, your androgen levels are most of the time not very high. There again, androgen levels are the highest in women which are obese, actually, and have higher age levels. So we generally do not try to get these levels down, especially not in women which are trying to conceive. Mm-hmm. Is that an answer to your question? Yeah.
Yeah, it is. But I'm concerned about number one is whether those androgen levels, if they are raised, would come in the way of her getting pregnant. Number one. Second thing is whether it would lead to an early pregnancy loss, and third is whether it would, in that androgenic environment, if the fetus is growing, would it cause any problems to that fetus?
Yeah, well, in that respect, it's of interest, of course. You know that I do a lot of stuff on AMH with DEA. I think you should try to lower AMH, and we don't have any means at the moment to do that. I think AMH is the primary driver of the hyperandrogenic environment which you are exposing your fetus to, and that has to do with the fact that AMH is a very potent inhibitor of aromatase activity in the placenta. And by doing so, we always thought the aromatase activity is so present all over the placenta. That's not the case, actually. Basically, it's an issue which is underestimated. And a recent study from the Lille group showed that women in the third trimester have higher levels of AMH, and cord blood levels of babies born from these women have higher androgen levels. So I think AMH is the indirect driver, and by just trying to, let's say, try to treat the result instead of the cause of that hyperandrogenism, yeah, I don't think that's going to bring you that much. And how would you like to do that? Because if you use finasteride or flutamide, which is off-label here in the Netherlands too, and in a lot of countries all over the world, you see a lot of side effects of these drugs. They do work very efficiently, and they do lower androgen levels. But there again, you need at least 3 to 6 months to lower them to a certain extent. And I really don't know. For instance, we looked at what other, let's say, factors are very much important determining your treatment outcome. If you are trying to get pregnant, it's ovarian volume too. It's whether you are oligomenoretic or anomenoretic too. It's also BMI, which is a very strong predictor. And it's, of course, also hyperandrogenism, but it's only 1 out of 4 which are important and also, in a way, determining this outcome. And I think in that case, I would very much more focus on losing weight, and I wouldn't bother about androgens that much in lean women, because I think they stand a fairly good chance to get pregnant.
Yeah. So in short, we have covered most of the areas all through the adolescent phase, through the infertility phase, the perimenopausal and the postmenopausal, and I think we have covered most of it. I think we have also covered a few questions which have come in. Is there anything else you would like to add, to whatever we have spoken?
No, but yeah, the only thing I would like to add, of course, you know that, is stick to the guideline as much as you can. and also stick to the important thing which I would like to stress, and it's not because I'm living in Rotterdam and I was one of the members of the Rotterdam Consensus, but as long as we are not talking about the same diagnosis and the same tools we use for that, we are comparing apples and pears, and that's not what we should do, because that's not going to work. Basically, it's about good comparisons, and if we do that all over the world in a similar way, then we might tackle, of course, issues which are very much related to where people are coming from and what the specific genetic background is, but also we are comparing similar things, and that's a very important thing to do. And treatment, as far as treatment is concerned, you have a lot of degrees of freedom to do what you want to do there, but there again, the guideline is trying to provide some guidance in how you could do that. And it's not a guideline like how the Americans would use it, that if you not stick to the guideline, that that people can sue you. That's definitely not the case with this guideline. This guideline is trying to provide guidance for diagnosis, for treatment, fertility treatment, for long-term health issues, and yeah, it's up to you what you pick out of it. It's not that you have all the degrees of freedom, because yeah, you should stick to a few things which are, let's say, taken as a leaving point before we started this endeavor, and now 3 years ago, the update is coming on to it again. So basically, some of the things some of the recommendations are probably going to change anyway.
Yes. Absolutely. So thank you very much, you, for sharing your time and expertise
You're
with
welcome.
us. It's been absolutely brilliant, your talk, and we've all enjoyed it very much. And I would like to then go on to just acknowledging all those who have been, who have helped us in this, in bringing on this webinar series to all of you. Our collaborator, Monash University, who has given us the support in taking this guidelines further, and our speaker, Professor Joep Levin, today, who has spoken to us on hyperandrogenemia and in PCOS. All our delegates who have been online, and USV for their logistics support in bringing us, closer. It looks like I'm sitting across Professor and talking, but we are sitting 9 hours apart, I think, by air.
Yep.
So it's been an amazing session, and there's been a lot of discussion. And I would like to talk about the next webinar we are having on the 30th of August with Professor Richard Legro, who's been part of the guidelines, and you have referred to him. And we will be discussing on the topic of optimizing ovulation induction in PCOS. But this session will be in the evening since Richard lives in the US, and this session will be between 7:30 in the evening to 9 p.m. Indian Standard Time. 30th August, we look forward to seeing all of you online for the International PCOS Guidelines webinars. We also have a program coming up in Mumbai with the International Society of Gynecological Endocrinology, where we will be focusing on PCOS in the adolescent and at puberty. So this is what we are going to have a very good course on this, and followed by a one-day clinical dilemma discussion. So we will request people who are from India, I'm sure, would like to register for this. So I'm using this opportunity to talk about this program, which is going to be November 9th and 10th. So thank you very much, you. Thank you for being with us. And,
thank you very much, and have a good evening.
Thank you, and thank you from Hindustan, and a big namaste to you too.
Bye-bye.
Bye.